Well, first of all, I'll let you introduce yourself because there'll be students that will be seeing this as well as those who go on to the Regis University page will have an opportunity to see this conversation. So we're glad to have you. So just tell us who you are and a little bit about what you do.
Okay. My name is Kimani Paul-Emile. I teach at Fordham Law School. I focus on health law, law and biomedical ethics, anti-discrimination law, and administrative law. I'm also co-director of the law school Center on Race, Law, and Justice, and I focus on our domestic programming. And I'm also the faculty co-director of our Stein Center for Law and Ethics. So I wear several hats at the law school.
Okay, that sounds very amazing. Looks like our other guest is joining us now.
Hi, sorry about that. I had to reset my password.
That's okay. It's a morning for a little bit of tech issues, but it's good to have you join us. I'm Lawana, and I'm a faculty member with Regis's nursing program, and we're here to have just a little brief conversation this morning. We have already had an introduction from Dr. Kimani Paul-Emile, and she is a lawyer and faculty member with Fordham University there in Brooklyn, New York, and specializes in healthcare law and in the biomedical aspects of that. And so we thought it would be good to have a conversation between the three of us. I've been having conversations with nursing leaders and also with other members of the community. The first one that we had was with Breonna Taylor's mother, Tamika Palmer. That was the kind of our kickoff conversation. So we're glad to have you join us. So would you just give us a brief introduction, Miss, is it Siversten? I want to make sure I pronounce it.
Siversten.
Siversten. Okay, of you, just tell us who you are and also what you do as far as work.
Certainly. So my name is Beth Siversten. I now am the medical ethicist for Grady Memorial Hospital in Atlanta, Georgia. That is Atlanta's safety net hospital. And I've been here, I joined right before the pandemic as their only medical ethicist on staff. Prior to this, I graduated from Harvard with my master's in bioethics, but I also worked as a SICU nurse in Boston at Mass General Hospital for many years.
Okay, so that's a connection because Regis is in Massachusetts as well, so that's great. So I'll tell you what kind of got us to this point. In one of the conversations that we had, I always give personal experiences, and I worked as a labor and delivery nurse before I became a nurse practitioner in a local South Carolina hospital. And one evening, when we were working, we had a patient come in, and the patient was, in kind of a little bit of distress. And in the middle of me getting ready to triage her, she said, "I don't want a Black nurse. I don't want a Black nurse. I need somebody else. Get me a white nurse." So here I am. I've probably been nursing about 3 or 4 years. And, you have little nuances of racist patients, but this was the first one that had said, "I don't want you." So I go into the hallway. So there's myself, the African-American charge nurse, and there's an Asian nurse that has been pulled from another floor from the nursery that really is like, I'm not the ideal person because she doesn't generally take care of pregnant people. So what do? I go back, I tell the charge nurse, she says, "Well, go back in and tell her what we have." So I literally went back to the patient's room and said, "Well, we have 2 African-American nurses and an Asian. Which one do you want?" And she said, "I'd like the Asian nurse." So, it made for a really hard night for us because we really were taking care of her because the Asian nurse didn't know a lot of what to do in that particular area. And on top of that, the physician's office that was on call, the physician on call was also African-American. So we had to inform him. So it brought to mind the question, first of all, Andy, who was listening in on the conversation, could not believe that had ever happened. He said, "I'm just not, it just seems like something antiquated." But I wanted to have a conversation, first of all, about, bioethics, what that looks like, and also about what types of things nurses need to know when it comes to legal aspects from your side, Dr. Paul-Emile, and also from the aspect of they're in the hospital inpatient care areas from your side, Miss Siversten. I don't want to pronounce it wrong. So Dr. Paul-Emile, will you start us off with, what your thoughts are? I know that you had an article that I read that was great on dealing with racist patients in the New England Journal of Medicine back in 2016 that was similar to the situation that we face. But what would you talk about when it comes to the legal aspects of what patients can demand and what nurses' rights are in situations like those?
Sure. First, I'm sorry that that happened to you. And unfortunately, these situations are much more common than people think. I call it one of medicine's open secrets because, you know, if you go to any hospital in the country, you'd be hard pressed to find a physician or a nurse who hasn't had this experience or who doesn't know someone else who has had this experience. And what makes these physician-patient encounters so difficult is that they raise many legal, ethical, and clinical challenges for all the parties involved. So, for example, if you accommodate the patient's demands, then are you discriminating against the assigned clinician? And then if you don't accommodate the patient's demands, and let's say the patient hasn't been screened or stabilized, then you could be violating EMTALA, the Emergency Medical Treatment in Active Labor Act, which requires that any patient who presents in an emergency department be screened and stabilized to see if they have an emergency condition. But then if you don't screen and stabilize the patient, then the medical institution could be, or if you force the patient, let's say, to be treated by an unwanted clinician, that could be battery. Right. And then there are issues of informed consent that are raised. So it's hard and it's really difficult. And in some ways, it's a legal black hole in the sense that in any other area of social life, if you went into a restaurant and said, I only want, the Black waiter, or if you went to a store and said, I only want the white, clerk, they wouldn't accommodate that. That's so clearly illegal. And yet in medicine, it's much more challenging.
It is. So from the medical side or the nursing side, what would your thoughts be on that, Ms. Siversten?
It's interesting because I've had a recent case in labor and delivery, a similar case. However, at Grady, much of our patient population is Black. We tend to have about 75% of our patients in a given year are Black, and a lot of our physician workforce are white. And so I ran into a case where a woman in labor, active labor, felt unheard by her physician. And the physician really didn't know how to communicate with her. And she said, I'm done with these white physicians. I need someone who understands me. And it was very hard. She was in active labor. We were able to work through it. And the physician didn't understand where the issue was arising. They didn't have the capacity to reflect on themselves and understand how the communication was breaking down. And so from my perspective in that case, what was hard was, here, the woman and her child might be best served by continuing with this physician. This physician has been following this woman for the entire day. She actually delivered about an hour and a half after this conversation. But to change physicians at that point in her labor might not serve anyone well. And so we really had to dig into this and figure out, how can we reestablish trust in this situation where you don't understand, or where you feel that the doctor didn't understand your frustrations, your stress, your anxieties that you're facing as you're in active labor. It's funny to see it from that perspective. As in your situation, I would say, the same thing. You might be the best equipped nurse to take care of that woman, and she doesn't understand that because all she's seeing is the color of your skin. And I think that's unfortunate. And we have to step back and look at, not just what the patient wants or desires, but how are you going to be able to provide the most good to this woman? Is it by changing clinicians and maybe having her feel more comfortable, or are you going to have to say, listen, that's just simply not possible. We can't, we need to find a way to work through this and have that conversation. But for the time being, I am the best one to take care of you, and I need you to understand that somehow.
Mm-hmm. I can see where that would be truly difficult, particularly in a highly charged environment emotionally that happens at the time of birth. But your comment does make me think of something else, and that is, how does the history inform where we are with bioethics, even now, because in the comments you made, with African Americans, of course, there has been, documented evidence of some of the things that have happened as far as bias with provider towards African American patients, perhaps feeling they have a different pain tolerance or other things that may have happened. So if I, as an African American woman, go in and ask for an African American provider, that choice may be driven by something that's different than the person that is Caucasian that refuses, So it's kind of like a different nuance to that. So how do each of you think the history has informed where we are now with that? And I'll start with Dr. Paul-Emile.
So I think you both raise really important points. The history does play a large role, and this is really sort of where the rubber hits the road with these kind of scenarios, because we know that trust is an important part of the clinician-patient relationship, right? You have to be open about your symptoms, about your lifestyle, in order to get appropriate treatment. And for some people, it's important for them to have a physician or a nurse who understands their experience and knows where they're coming from. And as you noted, Lawana, we have a very real history of discrimination and a well-documented history of discrimination in healthcare and in other areas of life in America. So it's important, and it's hard in these situations to distinguish between, garden variety racism, where the person is just, I don't want you, to a patient who's really just looking for someone who's going to understand their concerns, who's going to be sensitive to their needs, who's going to be able to for whom they'll trust. And that is the challenge for clinicians and healthcare institutions in these situations. Now, there are guidelines that they could follow to try and distinguish between these kinds of patients, have the patient, talk to you about why they're making this request. Is it based on fear? Is it based on, perhaps the patient has had prior negative experiences with a clinician of the race of the one they're rejecting, or perhaps they've had prior positive experiences with the clinician who they're of the race or ethnicity that they're requesting. You can explain that all the clinicians on staff are well trained, and as you both pointed out in both of your scenarios, you can point out that this clinician knows your case and is best able to provide you the care, and perhaps the person we bring on to cover for them might be less experienced and also less knowledgeable about you and your situation.
True. Ms. Siversten, would you add something to that?
I think there has to be a conversation about, there's history that probably can't be appreciated until you have that conversation. I always say my job would be much easier if we just had, functional communication at the outset, but often I'm coming in to do a little damage control. And I think it's really important to keep in mind that in any patient-provider situation, that patient is already going to feel vulnerable. And that, coupled with, the history of African Americans, feeling, having been exploited by the US medical system in the past, to be that patient in the bed and to feel vulnerable again, adds attention to any conversation. I think it's, it's important to acknowledge at the outset. This patient I told the story about felt threatened. She felt, the patient said the provider said we might have to do a C-section, and she felt the provider was threatening a C-section if she didn't comply with what they were saying. And there are ways of delivering these pieces of information that might not come across as so threatening to someone who's laying in bed that you're standing over. And in your story, Lawana, that patient might feel, vulnerable to someone that she doesn't reflect, like she doesn't reflect with you, she doesn't connect with you, and she might feel vulnerable. So I think it's really, important to notice the power struggle and to try to address it however we can.
So there at Grady, do you all have any type of training measures or anything that you do to assist providers with being able to navigate those type of situations there?
I'll say it's very difficult. We're affiliated with two different schools of medicine, both Morehouse School of Medicine and Emory School of Medicine. And so the schools really do their own training. We certainly are trying to have these conversations with our residents. It's very hard when you have a resident who's both learning medicine and learning how to talk to a patient, because they're concentrating on doing the medicine, not so much on how they're delivering this information. But we do have very knowledgeable nursing staff and other staff that can help bridge these conversations.
I know that in one of the newsletters that I read, because I know you also work with the Harvard Center for Bioethics, and one of the newsletters that I read that you had written something talking about ethics simulation training, and I had not heard that. Can you speak a little bit about that from the nursing side as to what that would encompass in your mind?
Right. It's a dream of mine to establish a program for this. But when I was a new graduate critical care trainee, we had 3 simulations over the course of my orientation and onboarding. We had a code simulation, a patient slowly decompensating, and the final one was a goals of care conversation. And you go into the simulation, you don't have the dummy patient in front of you. You have 2 actors, and they are the family members of this patient. And you're asked to be part of this conversation where you're delivering bad news. And I think it's so important to have that first experience of delivering bad news and being part of this tough, very tough, challenging conversation in a low risk situation. It should never be the situation where the first time you're learning how to deliver bad news is when you're actually doing it, because a lot of things can go wrong in that conversation. And you need to be so in tune with what you're saying and how you're saying it. And also reading the person across the table from you, reading their emotions and acknowledging them and addressing them. And so I think that would go a long way for, nursing training, resident training, to help them know how to have these conversations, how to talk to human beings who are suffering, and have empathy and to practice that dynamic.
I think it's an interesting concept because we as nurses are not often told how to have difficult conversations. And I think a part of that with the nursing, like for us, we always fall back to we got to take care of the patient. And so I think that at times we're willing to have practices that may be discriminatory, to have things that may be even bordering on harassment, just to be able to take care of the patient because that's what we feel called to do. So when it comes to that, Dr. Paul-Emile, how do we finesse that line between what is the nurse's right and when do we as nurses get to that point where it's like, well, this is more than what I think should be happening, and how do we finesse that? Because I'm not even really sure if another nurse came to me now, and I've been a nurse for 15 years, what I would tell her to do, in a situation similar to what I had, because there's nothing clear cut.
Right. So legally, so there's the ethics and the law. I'll talk a little bit about what legally, if an employer forces an employee to accommodate one of these types of requests, then the employer may have created a hostile work environment in violation of Title VII of the 1964 Civil Rights Act, right? We've heard of cases of nurses who work in residence, like nursing homes, where a patient's family will say, we don't want any, Filipino nurses treating grandma, and then the nursing home puts a sign on the patient's door saying, no Filipino nurses. Well, in those cases, and the nurse is sued, and the nursing home was found to be, have violated the law. And so it's similarly in the hospital context. If a hospital says, this patient doesn't want you, so we're going to reassign you, clearly illegal, right? It has to be a conversation. Sometimes the clinician is like, look, I don't want the patient either. They're difficult. And we know that medicine is as much an art as it is a science. And so under the best of circumstances, things can go wrong. And we know that when things go wrong, sometimes patients sue. And clinicians are like, look, I just don't want to deal. So this patient is a pain, and I just don't. And so it has to be a conversation. But then you have those clinicians who are like, look, I want to go through with this, and I need the support of the healthcare institution in that process, and they need to be there for the clinicians under those circumstances. In terms of broader policies for how to deal with these, I think healthcare institutions, have to have a written policy for when these racist patients or biased patients encounters occur. So a lot of healthcare institutions have difficult patient policies, but these are different, right? And so they should have specific policies for when the biased patient occurs. And I think so there are three different, let's call them interested parties, right? You have the rights of the patient, you have the rights of the clinician, and then you have the obligations of the healthcare institution. Let's focus for a moment on, we talked a little bit about the patient, let's talk about the clinician. When these instances occur, they have to feel supported, so it's important for the healthcare institution not to diminish it, for the affected clinician to have the opportunity to talk to a trusted point person, to have a debriefing. So, I mean, we talk a lot about microaggressions, but this is a macroaggression, and we know it happens more frequently to certain providers, providers of color. And each time it happens, it's like it's like a slice of the knife, and the cumulative effect can be significant, and that leads to burnout. And burnout, as we know, is a real problem in the profession. But I also recommend that institutions don't just have a debriefing session with the clinician involved, but actually with the whole team. The whole team needs to know how to deal with these encounters, because even if they don't experience it themselves, they're likely to see a colleague going through it. And they have to be able to support the colleague in those circumstances. And then there's also sometimes a colleague who doesn't even know what's happening because of their own demographics. It doesn't happen to them. And so it's important for them to be on notice that this is what's happening in the workplace, and they all have to be know how to support their colleagues when these occur. I can also talk a little bit more about what an appropriate institutional response would look like, but I'll save that for later.
Okay. Well, Ms. Siversten, I want to ask as well, there at Grady, when you're having these conversations, is there a committee, or are you pretty much the point person for each of these incidents? And how difficult is the managing of those conversations that you're having to have?
I'll say I really like Dr. Paul-Emile's point about having a policy about how to address these situations, because I have a feeling that these situations are happening, and they're happening on the unit level and being managed probably very idiosyncratically based on the situation, but not necessarily arising to the level of acknowledgement by leadership. Mm-hmm. We have a brand new chief of diversity and equity established as of, I think, October, but we haven't had that department to address these situations prior to this, and so I do think it's been stuck at a unit-based or departmental level. I'll say we talked about maybe you're the best provider to care for a patient, but I think on the other hand, you talked about how to advise your colleagues, or what advice you would give to a nurse facing this situation. I think it would be very important also to check in with yourself and be conscious of whether this is going to impact the care that you are able to provide to this person as well. And like Dr. Paul-Emile said, these incidents can build up and lead to burnout. And so I think, being in tune with yourself to know how you're feeling about this, how you're able to deliver care in this kind of context, and then to know, how much is too much. I think, we have an obligation to provide care, but it's a supererogatory, which, asking too much, asking more than what you're obligated to do. If you feel, threatened, if you feel defeated in acquiescing to this, either acquiescing to the demand or continuing to provide care. I think, it takes a lot of self-knowledge to know how to do this. And that's probably going to be very hard for young professionals in this context, and can absolutely lead to burnout.
Yeah, when you're coming in as a young nurse, there's so much that you have to learn. And it's interesting. I was telling Andy before we talked today that I've been nursing for a long time, been Black my whole life, obviously, but these things lie beneath the surface of our skin, you know, for those of us that are people of color. And a colleague of mine recommended that I read a book called Small Great Things. So if neither one of you have read that,
I was going to bring that up.
Yeah, Small Great Things. So I'm going to tell you, I got the book. And I worked in labor and delivery and had been in situations like this, and I could not finish it. I'm an avid reader. I mean, I can read, run through, but I love it. But I could not finish the book. I still have it, and I haven't finished it because it brought so much to the surface in me personally from having, it was triggering. I started reading, and I was like, oh no, I can't read this because I felt like if I finished it, I might not be able to approach my work in the same way. And so those triggering things, I think it's interesting that you mentioned, Elizabeth, that you need to think about how you can provide care as a nurse, whether it will affect the way you provide care. Because I was telling Andy that there's certain things that I can watch and ingest about racism and things that are happening, and certain things I choose not to, because I feel like ingesting those things is going to put me in a space where I can't deliver the care that I need to, that I want to give, you know, to my patients, regardless of their bias. So the conversation has so many different nuances from that standpoint. But I do want to touch on something else. You know, we can't talk about health at all without talking about COVID. I don't think we'll ever be able to talk about health without COVID because of the way it's changed things. But what a lot of people have not had a conversation about in the general public is the ethics surrounding COVID. Each of you working, I apologize. Each of you working in around bioethics, talk a little bit about the issues that have come up. I mean, we have vaccines, we have masks, we have hospitals making mandates about masks and nurses not wanting to, about vaccines. We also have what may be happening in the hospitals, and maybe you can speak to this, Elizabeth, too, is the rationing of care. For, you know, hate to use that term, but those things that are going on. Can you speak a little bit about those issues surrounding COVID that have kind of brought some issues underlying in healthcare in general to the fore? Each of you, please.
I guess I'll give the boots on the ground COVID situation that I've seen. I think top of my list is the visitation restrictions. I think, you know, that when we weren't allowing visitors except for end of life situations and very few other exceptions, there was, you know, your loved one was taken behind, you know, basically a curtain, and you didn't know what was happening in the hospital, and that was hard to deal with, given the historical and systemic racism that, you know, African American patients have faced. They didn't trust that we were going to take care of their person in the hospital. And so it's been better now that we're allowing visitation. It's still restricted to some degree, but that has at least alleviated a lot of the tension that we saw initially in COVID. I'm very worried about the vaccine mandates. I think, you know, I've seen, you know, hints of Black Lives Matter beginning to say they're going to protest these vaccine mandates as being, you know, structural racism intervention or implemented. I worry that, you know, our physician population was on the bandwagon getting vaccines as soon as they were available, but our environmental staff, the people that take the trash out are very worried about this. I talk to our patient transporters and they're scared of the vaccine. And so we've had to, you know, and I hate to, you know, not say this outright, but like I said earlier, our physician workforce is white or, you know, not of color. And, you know, our nursing staff is largely of color. Our EVS staff is largely of color. And these are the people who are going to be affected by the mandate, and they are scared. We're doing as much as we can to reassure them that vaccines are safe, but I do feel that, you know, now being forced with a situation, it can be untenable for them to be told, get the vaccine or lose your job. I hate to think how that could affect their life situation. And so I've been very worried. I'm keen to hear how our requirement as of, I think, October 1st is going to affect our staffing levels, and if we're having people resign due to this. because they're simply scared. It's not because they don't, they don't believe in the vaccine. It's because they are scared of the medical technology behind this. And then we are seeing communities of color affected by this. The hospitals around Atlanta that don't have, 75% of their patient population of color, day to day, are seeing more patients of color come in. And I don't know that they know how to treat them with respect. I don't know that they're capable of providing the reassurance that Grady is, unfortunately.
Mm-hmm. Yeah, that's a lot to think about. Dr. Paul-Emile?
So, we're experiencing some of the same issues up here in New York. There's a lawsuit, I think, that's been brought by, I'm not sure what, it's not the physicians, but it's also other sort of medical personnel against the mandate. So we'll see what happens. But, there is a long history of, vaccine mandates and public health and workplace safety mandates. So in my sense is most of them will be upheld as long as there's some sort of religious exemption. But we're seeing this happen throughout the country. And, sort of bringing COVID back to the initial topic of patient bias. Initially, when COVID first appeared, there were more increased reported cases of healthcare workers who presented it as East Asian being rejected and by patients. And part of that was related to the words of our former president calling the coronavirus the China plague and the Kung flu, and a lot of just misinformation and just not a lot of hard data on the virus. And so there were a lot of reported cases of Asian Americans being rejected by patients. And so this issue just sort of got even more, there's more awareness of this issue, and that's due to coronavirus.
Mm-hmm. Yeah, I think that there is definitely an issue. I mean, I know personally of a couple of personnel that I know that work at Grady, because we're not that far from Atlanta, and that have had a lot of angst internally over the issues surrounding that. I had a conversation yesterday with Dr. Ernest Grant, who's the president of the American Nurses Association, and he was speaking to something that you all have talked about, which is the fact that conversations happening, not just on the major levels, but even on the one-to-one levels about, the bioethics, the legalities, about the fears people have, because so much of what we've seen in the last year and a half from COVID has arisen from fears, those fears that were there that weren't addressed properly. And I think that's why we found ourselves, in the situation that we are now. So clearly there's a lot for us to talk about, a lot for us to think about. And but what gives me hope is that we have great minds, people that are great minds in the law, like you, Dr. Paul-Emile, and then people who are like you with a blend, basically, of some of the legal aspects as well as the actual biological ethics side there, Elizabeth, in Atlanta. So I'd like to close by asking, despite the situation that we find ourselves in now, what is it that gives you the most hope as you look in the days ahead? What are you most hopeful about from the standpoint of bioethics right now? And I'll begin with you, Elizabeth.
Oh, you're beginning with me. It's so funny because it is really hard to feel hopeful. And I'm hoping I'm hoping that we're on the other side of the surge that we've been facing for about a month now. I'm seeing people come together. I think there's been a lot of breaking down of who would otherwise be a normally strong person. We're being asked to make, not just decisions about what's safe in the day-to-day provision of care, but, decisions about, something as stupid as going into the grocery store. Do I wear a mask? Like those moral decisions that we're facing in every aspect of our day-to-day lives they're heavy. and they weigh us down. And I'm hoping that as we move forward, there are fewer of those decisions, that we feel safer around the people that, that we're surrounded with, that we're able to come together and lift each other up. I really do feel like, we've seen a lot of burnout, but at this point we are rallying, and it's forced some measures to make sure that we have adequate staffing, to make sure that we are having these conversations with families in a way, that's compassionate. I do think, I think that we're just summoning up a great strength right now, to face whatever else might be out there. We've been through so much, and I think we can get through this at this point.
Mm-hmm. Dr. Paul-Emile, what about hope for the future?
Sure. So this might seem, the last couple of years have been very dark, but I have to say, through that darkness, I think we've created opportunities for light and ways to move forward. I think, in this moment of sort of Black Lives Matter and people talking more openly about race and inequality has, or just sort of elevating these issues, has been in many ways a good thing. I think after the election of Barack Obama as the first Black president, there was this sort of broader narrative that this country was post-racial. And so we no longer had to deal with race. We had a Black president, so it was all taken care of. And the last couple of years have shown us that no, we still do have a lot of racism, and and because it's become so much clearer, we can actually talk about it in a way that will allow us to move forward with real concrete measures. And that, and we see this with the issue of biased patients. We see that, there are some bad apples. That's part of the problem. So, some racist patients, but there's also a lot of structural racism in the healthcare system that takes us back to the mistrust that we see among communities of color when they go to seek healthcare. So that's sort of we see the discrimination really on both sides. And I think now we're able to talk about it and move forward in a way that may not have been possible 4 or 5 years ago.
That is such a hopeful note to end on. And I will tell you all that what gives me hope as well is that the fact that we can have a conversation about race and have each of us be of different skin tone and still have a conversation that centers around the well-being of everybody involved. And my first eye-opening experience with that was I took the first African-American history class I took was an online class. And the first thing the professors did, everything in the course was blocked until you read his bio and watched his video. And the guy was white. And, everybody took a deep breath. And he said, I say this because most people coming into an African-American class would think that the professor would be African-American. But I will tell you that I learned more about things in history. And it was a very eye-opening experience. So that I think is good, in that we know that we can have conversations about what's going on, and the different aspects of it is what's going to really bring us to the truth of the matter and allow us to move forward. And so it's been my great pleasure to have both of you talk with me this morning. And I hope that the students who watched will be able to speak to this as they go into their practice, because they're the next generation coming up. I've been nursing for 15 years, and I probably got another 15. Maybe I started late. I didn't start till I was 36. So I'm not going to be around for another 30, but we're hoping that the ones that are coming along that you all are talking with and are informing will be able to move us to a better space than where we are now. So I appreciate both of you, and I do wish both of you well in the work that you are doing. And please give a special shout out from Regis to the nurses there at Grady. I won't say that I want to be on the front line, but I will tell you that every nurse wishes that they could have the skills they need to help. At this time, we have to work in other areas, but we certainly are appreciative of all the efforts that are going on there as well. So thank you both, and enjoy your day.
Thank you for having me.
Bye-bye.